On this channel, we explore concepts in clinical reasoning and medicine in a simple and systematic way. Let's get started. Now we will discuss about SGLT2 inhibitors in diabetic nephropathy. Sodium glucose cotransporter 2, or SGLT2 inhibitors, are currently considered a cornerstone therapy for patients with diabetic nephropathy and chronic kidney disease, or CKD, particularly in individuals with type 2 diabetes mellitus accompanied by albuminuria or declining renal function. Originally introduced as anti-hyperglycemic agents, SGLT2 inhibitors have demonstrated substantial renoprotective and cardioprotective benefits independent of glucose lowering. Major randomized controlled trials, such as Credence, DAPA-CKD, and EMPA Kidney, have shown that these agents significantly reduce progression to end-stage kidney disease, ESKD, reduce albuminuria, slow eGFR decline, and decrease hospitalization for heart failure and cardiovascular mortality. The mechanism of action of SGLT2 inhibitors involves inhibition of the sodium glucose cotransporter 2 located in the proximal convoluted tubule of the kidney. Normally, this transporter reabsorbs approximately 90% of filtered glucose. In diabetic nephropathy, increased glucose and sodium reabsorption contribute to glomerular hyperfiltration and intraglomerular hypertension. By blocking sodium and glucose reabsorption, SGLT2 inhibitors restore tubuloglomerular feedback, leading to afferent arteriolar vasoconstriction and reduction of intraglomerular pressure. This mechanism reduces albuminuria and protects nephrons from ongoing injury. In addition, these drugs lower blood pressure, decrease body weight, improve metabolic efficiency, reduce inflammation and oxidative stress, and may attenuate renal fibrosis. Several SGLT2 inhibitors are widely used in clinical practice. Empagliflozin is commonly prescribed at 10 mg once daily and may be increased to 25 mg daily if additional glycemic control is needed. Dapagliflozin is generally given at 10 mg once daily, while canagliflozin is usually initiated at 100 mg daily and may be increased to 300 mg daily in selected patients with preserved renal function. Ertagliflozin is administered at doses of 5 to 15 mg daily. Among these agents, empagliflozin and dapagliflozin are most frequently recommended for diabetic nephropathy because of strong evidence supporting renal protection. Current KDIGO and ADA guidelines recommend initiating SGLT2 inhibitors in patients with type 2 diabetes and CKD when eGFR is at least 20 milliliters per minute per 1.73 square meters. Previously, initiation thresholds were higher, but recent studies demonstrated renal and cardiovascular benefits even at lower eGFR values. Although glucose-lowering efficacy diminishes as renal function declines, nephroprotective and cardioprotective effects remain significant. Once therapy is started, SGLT2 inhibitors may usually be continued until dialysis initiation or kidney transplantation, unless contraindications or severe adverse effects develop. A transient decline in eGFR commonly occurs after initiation of SGLT2 inhibitors due to reduction in intraglomerular pressure. This initial decline is generally mild, often around 3 to 5 milliliters per minute per 1.73 square meters, or approximately 10 to 15% from baseline, and usually stabilizes within several weeks. In most patients, this hemodynamic effect is considered a marker of renal protection rather than nephrotoxicity. However, clinicians should evaluate patients carefully if eGFR declines by more than 30% after starting therapy. SGLT2 inhibitors are generally well tolerated, but several adverse effects should be monitored. Genital mycotic infections are the most common side effect because glucosuria promotes fungal growth. In clinical trials, genital fungal infections occurred in approximately 4 to 12% of women and 3 to 5% of men, compared with lower rates in placebo groups. These infections are usually mild and respond well to antifungal therapy. Urinary tract infections may also occur, although the increase compared with placebo is modest, generally around 4 to 9%. Volume depletion and hypertension can occur due to osmotic diuresis and natriuresis. Symptoms such as dizziness, dehydration, or orthostatic hypotension are more likely in elderly patients, individuals using loop diuretics, or patients with low blood pressure. Clinically significant volume depletion occurs in approximately 2 to 5% of patients. Careful monitoring of hydration status and blood pressure is therefore important, especially during initiation. Diabetic ketoacidosis, or DKA, particularly euglycemic DKA, is a rare but serious complication. The estimated incidence is generally below 0.1 to 0.3% in clinical trials, but may be higher in patients with insulin deficiency, prolonged fasting, acute illness, or perioperative states. Patients should be educated regarding symptoms such as nausea, vomiting, abdominal pain, and rapid breathing. Temporary discontinuation during surgery, severe infection, or prolonged fasting is recommended. Canagliflozin was initially associated with increased risk of lower limb amputation in the CANVAS trial, with rates approximately 6.3 versus 3.4 participants per 1,000 patient years compared with placebo. However, later studies showed inconsistent findings, and the overall amputation risk remains uncertain. Monitoring is advised in patients with peripheral vascular disease, neuropathy, or diabetic foot ulcers. Another uncommon adverse effect is Fournier gangrene, a rare necrotizing infection of the perineum. Although extremely rare, this complication requires urgent medical treatment. Acute kidney injury may rarely occur, particularly in patients with severe dehydration or concurrent nephrotoxic medication use. But overall evidence suggests SGLT2 inhibitors actually reduce long-term AKI risk. SGLT2 inhibitors also provide substantial cardiovascular benefits in diabetic nephropathy. Clinical trials consistently demonstrate reductions in hospitalization for heart failure by approximately 25 to 35% and significant decreases in cardiovascular mortality. Additionally, albuminuria reductions of approximately 30 to 40% are commonly observed within several months of treatment initiation. These benefits occur even in patients already receiving maximal renin-angiotensin system blockade with ACE inhibitors or angiotensin receptor blockers. Because of their strong renal and cardiovascular protective effects, SGLT2 inhibitors are now considered standard therapy in diabetic nephropathy management, alongside blood pressure control, renin-angiotensin system inhibition, glycemic optimization, dietary modification, and cardiovascular risk reduction. Their ability to slow CKD progression and reduce major adverse renal outcomes has significantly transformed the modern treatment approach to diabetic kidney disease. Thank you for following this discussion. In clinical practice, what matters is not just what we know, but how we think. See you in the next discussion.